You're listening to Beyond the Endpoint, a podcast from the Duke Clinical Research Institute. In this series, we're demystifying clinical research and answering your pressing questions about health and healthcare. You can find our full episodes at dcri.org/BTE.
Nearly 40% of Americans have experienced back pain in just the last 3 months. Sometimes we're fortunate and it subsides within a couple of days, but too often it never really leaves. And that chronic pain can reshape every aspect of life, including work, relationships, even getting out of bed in the morning. Despite its widespread impact, the advice for managing chronic back pain is often conflicting and ineffective. However, new research offers hope for a better approach. Today, I'm delighted to be joined by my friend and DCRI colleague, Dr. Stephen George, whose research focuses on biopsychosocial models for the prevention and treatment of chronic musculoskeletal pain disorders. Steve, thanks so much for being here.
Thanks a lot for having me. Looking forward to the discussion.
And I'm noticing as I, read through that last sentence, you all in musculoskeletal disorder research, you like words with a lot of syllables.
I think that is fair to say. And, outside of the US, it's musculoskeletal. So, there are nuances to those syllables too. But yeah, I think, compound words are something that we are into.
What's nice about having you on a podcast is we can break those down, right? We can sort of look behind those big words and let people know what they mean. Tell us a little bit about why you were drawn to this field of research in your professional journey. Was it these super long scientific terms?
No, and anyone who trained with me clinically knows that super long words were not my strength. But I was practiced as a licensed physical therapist. I worked in the University of Pittsburgh Medical Center for about 6 or 7 years full time. I saw a lot of people with back pain and shoulder pain and neck pain. And, that's where the musculoskeletal comes from. That's kind of grouping all of those together because they do have some commonalities. But back pain in particular, as a practicing clinician, learned pretty quickly that what we were supposed to do was not really working. And listening a lot to patients and seeing the results being subpar really bothered me. And when I was practicing, there were some seminal studies where people were doing imaging studies of folks that did not have back pain. And they were finding some of the same, structural changes in the spine as people that had pain. And this was really, really interesting from a clinical perspective because those findings were things that were supposed to drive the pain, drive some of the functional limitations that come from the pain. Really good studies looking at MRI results and CT results showing around the same rates of like disc herniation and narrowing of facet joints in asymptomatic people versus symptomatic people. And that got me thinking, well, what is going on here? So that type of work led me to think about research. And I was lucky enough to be in an academic setting, and there were some mentors around who encouraged and facilitated that. And eventually I started studying one of those words, the psychologic influence on the pain experience. And when I was studying it, I think there was an accepted influence of that. But when I started doing my own research, that area exploded and there was a lot of interest. And I worked in the assessment and then building treatments that address that psychological part. And then that's kind of moved into now more system level research where we're trying to test care pathways that have non-drug options, testing their effectiveness, seeing if they can be implemented. Because even though this knowledge has been around for a while, the way care is delivered hasn't changed dramatically enough to reflect the science. And I don't think that's unique to back pain, but I do think that is part of the reason, it can be a frustrating and challenging condition is the healthcare system was set up for the model where we identify something on an imaging study and then we know exactly what to do. And that basic assumption, was challenged many years ago and led people like me to look at other angles.
It also sounds like it might be true to say that you were the data nerd of your practice team.
I do remember in hindsight being that person who said, hey, did you look at this article? And a lot of people were saying, hey, have you looked at your schedule? Like maybe you should focus on your, who's on your schedule today. The data part is interesting, a little bit of a tangent. UPMC, when I was there, was one of the few physical therapy systems that was implementing patient-reported outcomes. So I had access to patient-reported outcomes earlier than a lot of therapists. And I love those. And in fact, I was one of the people who kind of started using those at high rates. And it was so helpful to see from the patient lens. We operated in a lot of 4-week windows. The initial insurance approval was for about 4 weeks. And you could see some people have these rapid improvements over 4 weeks, and some people didn't improve at all. And some people maybe even got worse. And unless you're using those PROs, I don't think it was as obvious, because of course everyone tells you, yeah, it's fine. And they liked coming to PT. But having that data nerd part and having access to those PROs was really helpful. And in fact, that was one of my first research publications, was just having patient outcomes over 4 weeks using the treatment classification approach for back pain. That was new. And that was my bridge. That was the jumping off point to then the people who were mentoring me said, you might want to think about doing a PhD, because not everyone collects outcomes for a year and then reports them out like that.
You're doing a PhD without really knowing it, right?
I thought I was just paying attention, honestly. I was like, this is interesting stuff.
I know it was a launching point for what's really become a pretty exciting time for you, I'm sure, given the growth in appreciation of patient-reported outcomes and doing this embedded research within a health system, which we'll talk about. I wanted to sort of zoom out for a bit just to kind of get a sense of the problem. And I'll confess, I'm a bad epidemiologist with respect to chronic back pain, because I don't even have a good sense of how frequent it is and the sort of daily impacts beyond anecdotes from friends and family and sort of things that we've seen in the news. But can you give us a sense of the high-level landscape, why it's so common, and kind of what we see in terms of the major impacts on people's lives?
Part of this, and as an epidemiologist, you'll appreciate this, part of this depends on how back pain is defined. When people do the survey studies, there are all kinds of definitions for, have you ever experienced back pain? And if you ask it that way, almost everyone reports yes. So that's where you get some of the really, really high prevalence reports. If you temper those questions and ask, have you ever had it for 48 hours to a week? You'll see some lower prevalence ratings. And then what we've been focusing on is a more recent definition that incorporates both the frequency and the impact of the back pain. And it's this concept of high impact chronic pain. And back pain is one of the most common forms of high impact chronic pain. So now it's not only something that maybe you frequently have, but it is interfering with your daily activities almost every day. And that's, when you look at the population studies that have been done, that's about 8% of the population. Now, what's interesting is when you look at people that are seeking care, obviously that's a lot higher, because people do tend to seek care, when their activities are interfered with. In a recent trial that we just completed in the VA, 60% of the people that enrolled in our study from primary care, this wasn't even from a chronic pain clinic, from primary care, 60% reported having high impact chronic pain, which means it was interfering in their life almost every day for 3 months. So part of it depends on how it's defined, and part of it depends on where you're looking for it. And I think the other challenging thing with back pain is, as you mentioned, it does resolve, but when it becomes chronic, it tends to be resistant to treatment. So even if you have relatively small numbers, 8 to 10%, those really are only being added to. There's not a huge reversal going in the other direction. And that's where you end up with what we see, which is a fairly large societal impact on cost of care, lost work days, quality of life, things like that.
It also sounds like one of those conditions that really is difficult to understand in terms of impact until you've experienced it yourself. I know there are a lot of sort of misconceptions and frustrations that people deal with as they're sort of becoming accustomed to this new way of living. Can you tell us a little bit about the patient experience when people first start to develop it to the point of needing to go get care for it, and what that's like in terms of their journey?
Full transparency, I have not actively treated patients in a while, but certainly we interact a lot with people through our research, through its qualitative reports and testimonials and things like that. And I think frustration is one common theme that you hear, because as you mentioned, until you really have it, it's hard to understand, and it's hard to understand how exactly it's going to impact your life. It does tend to come and go. So there's some frustration in that it can be unpredictable. Some days you can feel really good and you're able to do a lot of what you want, other days, not at all. That leads to, some challenge in how do I, move forward with this? And I think we can add confusion to the list when people seek care, because there's high variability in what you're going to experience when you go see a physical therapist or when you go see a medical doctor. And part of that, I think, is rooted back to the original theme where, if we do the imaging of your spine, it may look terrible and you could feel pretty good, or it may look great and you feel awful. So some of the things, that the health system likes to link in on, if this person has a herniated disc, then this is what you do. That adds to the confusion. If you saw me, I would say that imaging doesn't really tell us that much. We're going to look at other things. And then there's some practitioners that are going to make a lot of decisions off of the imaging, for example, for surgery. So I think that frustration, challenge, and confusion are kind of the negative valence. On the flip side, there are opportunities for self-management in back pain. So I think using that as a way to empower is really important. And some people in the chronic pain field have suggested, diabetes is a good model for that, where there is a well-known, self-management component, and that really can impact your quality of life with the disease. The other thing is, which the medical system doesn't always do, is in almost all cases, you can remain fairly active with your back pain. You don't have to wait until the pain subsides to resume your activities, because unless it's one of the very rare instances, where rest is indicated. And when I say very rare, I mean like less than 1%. Activity is actually probably something you want to maintain.
Pain in general, I know, is quite complicated given the, as you mentioned, psychological factors and the social factors, behavioral factors that go into it. But I really like the kind of glass half full perspective that you offered, that the good thing as scientists who want to improve care is that we do have a lot of potential targets, so to speak, for intervention and management that go beyond just what somebody might do in a 15-minute clinic visit, for example, which I know is providing a lot of hope for a lot of people. One of the studies in that space that I wanted to talk a little bit about today is the PAC-BACK trial, which I know you're an investigator on. And that's looking at a couple of different approaches, some of which seem maybe a little more cutting edge than others. But can you tell us a little bit about that study design and what the final results showed from that comparison?
Sure. Yeah. Thank you. And yeah, this is recently published and a very interesting and hopefully informative study. Spinal manipulation, which is a manual therapy treatment commonly delivered by doctors of chiropractic and doctors of physical therapy. In this study, both of those providers worked to deliver the spinal manipulation. And there's a lot of evidence to suggest spinal manipulation provides short-term pain relief. And some people have substantial relief. And that's part of the reason why it was selected for this trial. It's included in a lot of practice guidelines as a recommended treatment. The supported self-management was the biopsychosocial treatment. This was a little bit more about, education and coping and activity pacing and things like that. So this is a little bit more of a psychologically informed approach where it's not true counseling, but it is taking in behavioral principles and education principles and hoping to see some change in the person's behavior, beliefs, and even their attitudes about having back pain and kind of pushing them in the direction of that activation approach. Then there was the combination of those two, like a combo meal, putting those two together. And the usual medical care was the comparator, and that would be, what you would get if you saw a physician. And I think in this, they tried to make sure there was some medication provided and there was some standard education. So the trial had 1,000 patients randomized, which is large for back pain. I know that the size of the trial is relative to the area, but that's a fairly large low back pain trial. And really the take-home message is there are some opportunities to see better outcomes in disability, patient-reported disability, not patient-reported pain. The groups were fairly similar for the pain intensity levels, but the disability, which is kind of that interference or what you're able to do, was better if you received the supported self-management alone or with spinal manipulation compared to the usual medical care. So this trial suggests there may be opportunities for people to have either supported self-management or in combination with spinal manipulation earlier, because a lot of times you go see your doctor, they give you some medication, here, do these exercises. And if that doesn't work, you come back in 8 weeks. And then you get referred to see a DC or a DPT for some of these treatments. One of the things this trial did was move all of those up to front line, if you will, and people were getting those right away. And in the case of supported self-management, either alone or with spinal manipulation, there were some improvements that were clinically, they were in the small range, but they were statistically better than the usual medical care.
That's incredible. And of course, my mind goes to, okay, how are we going to get people access to these approaches? How are payers interpreting the evidence?
There definitely is interest in paying for non-drug options. Some of the existing barriers, are for physical therapy. The copays tend to be really high because they're considered, like a specialty treatment. So with PT, the copayments sometimes in the real world end up being a deterrent because you can pay more in one physical therapy visit than you would for, a 2-month prescription of pain relieving drug. For chiropractic, I think there's still growth in coverage, but we're seeing more and more of that. So there is some evolution in that direction. There's also this interesting tension. Historically, that's not where health systems have made a lot of money because it's not a lot of procedures. And if more people move in that direction, there'd be maybe less billable things in other areas of the health system.
Yes. Another type of chronic pain is fee-for-service structure in our health system, as we all know too well.
Right.
And you're touching on some important things here, which I think are, unfortunately, the people who bear the brunt of it are patients who don't have access necessarily to the best evidence-based treatment, or when they get access, it's way behind when the evidence first became available. If you were to just start from scratch and build a system that optimally supported management of chronic pain, what are some of the high-level features you think that might actually make things more optimal in terms of patient outcomes and evidence-based care?
We've thought about this and worked on this with people like Christine Gertz and Nikki Hastings at Duke and then Julie Fritz at Utah. We've actually published a kind of aspirational approach. And just to summarize that, the very first thing you have to be assured when you have chronic pain or back pain is there's nothing serious going on, because there are rare instances. So the health system has to be nimble enough to say, Emily, we don't think you have cancer or fracture that's causing your pain. And after that initial decision is made, then she has a period where she has access to acupuncture, massage, chiropractic, physical therapy. And all of those, the evidence for those is pretty consistent. So you could even have a model where you self-select to which one you go to, because some people think that patient preference in chronic pain is really important. Then we would monitor you, and people who are getting better would stay at that level. People who aren't, maybe would get a little bit more of an investigation. And that's where you would start bringing the specialists in to see, are there some surgical options? Are there options for injections and things like that? So a lot of it is flipping it, finding out very quickly that this isn't a serious medical systemic problem, and then getting access to some of these non-drug options in a way that is fast, efficient, and doesn't come at a huge cost, that it is covered. And a lot of places don't operate that way.
Speaking of innovative approaches to care that aim to be a bit more efficient, one of the areas that you and I have worked a lot together in is pragmatic trials and trying to learn about how to do them better and to use resources that we already have, like data within electronic health records, to facilitate more research and faster research, better research. And Steve, I'm just sort of thinking of you as this bright-eyed new researcher with your new PhD, and you're fulfilling all of your data nerd dreams. And then you start doing pragmatic trials, which are, as we know, quite messy, quite complicated, require different kinds of partnerships, a different way of thinking about data. Tell us a little bit about why pragmatic trials might be particularly well suited for this area of chronic back pain, and any sort of war stories you want to share.
I'm chuckling a little bit because of the bright-eyed bushy tail, I think, but also because Lynn DeBar and I, who's a member, of the collaboratory, just talked to some people at the United States Association for the Study of Pain about this very issue. So I'm going to try to paraphrase. I do think pain research has been fixated, is maybe too strong a word, but I'm going to use it anyways, on efficacy and can it work? And you need people who are willing to test, does it work? And that's exactly what you were saying. Like, I got a little tired of reading all this can it work for 4 guys in Milwaukee type of study designs that are highly selective, highly internally valid, and you see these fantastic results. And now what happens when we release it in the wild? And I do think having a clinical background helps in working in pragmatic trials, because I've wandered through the halls of a hospital. I kind of know what it's like being there. And I know it's not a perfect system and there's lots of opportunities to improve on care delivery, but you also have to be patient and work within the system. You can't just come in and say, this is terrible, it needs to be fixed, and I know the way to do it. That's just not going to work. So I think having a clinical background helps you temper your expectations, and you can just kind of be a different type of annoying data nerd. Now I'm the annoying, like, I think we can do this nerd, or the person who's just constantly pushing the project in the right direction, but not so much that it brings everything down on top of it. Again, not to mention Nikki twice. She's a health service researcher who's also a geriatrician and has worked in the VA. So she understands that system and what its limits are and where we can stretch them. And I think that knowledge is so important for pragmatic trials. But you have to have people that are willing to move it from the efficacy, can it work, which pain research, like I said, has been fixated on, to now, is this actually something that a health system like Duke could deliver to anyone who wanders into their clinic with back pain? I know that's something Christine Gertz has been working on too. And that move from the can to the does is a huge challenge.
In some ways, I feel like the field is fighting a bit of an uphill battle with the movement from can it work to does it work, with a lot of the chatter on social media around innovative approaches that are outside the mainstream. And chronic pain is sort of an interesting one because, as you said, there is a lot of treatment guidance that is inclusive of some of the therapies that we might think of as less evidence-based historically, but that we started to see more of an evidence-base develop around. What do you feel the current climate is like right now in terms of the information that people are bringing in from what they read on the internet or see on TikTok? Are people better informed than before, maybe informed about things that are not really evidence supported? Is your sense that this is a sort of growing problem, or do you think maybe people are becoming more educated and that's a good thing?
I do think exposure to information is generally good. And at the provider level, part of your job is to be able to explain why or why not you're maybe going along with the latest TikTok. That is actually one of the things. I don't spend a lot of time on social media, but people will bring me things. Can you believe this? And, for chronic pain, especially I'm thinking more of the person experiencing it now. Anyone who claims it's a cure is either, going to eventually be a Nobel Prize winner or is full of, malarkey. So I tend to err on the side that people who are claiming, this cured their back pain just had a really good short-term outcome with it. And there's nothing wrong with that. But claiming that it's a cure is really, I think, damaging to people that experience it, because what happens if they do it and they're not cured? Now they start, blaming themselves because they saw something. And I don't know that this is new. Probably the volume of it and the way it moves through channels is obviously a lot faster. But I remember practicing in the 90s. There was a lot of interest in running shoes back then. And people would come in and, they would have their foot evaluated somewhere and they would basically want to know what I was thinking. And there was a good Consumer Reports article on how to get a running shoe. And I had Xerox copies of that. And I would just give it to people. And I would say, I actually read this and I think it's great. These are the things that I think you should look for in a running shoe. Now, good luck. I think being able to react and respond to that in a measured way is really important. It also, by the way, helps you develop a rapport with the person that is seeking your care. And we know that's really important for chronic pain. Having some therapeutic alliance is really important. And showing the person that you listened is really important. So I can't shut everything down on social media and say, oh, you shouldn't be on there. But giving the person a chance to vocalize what they've seen, understanding that it's probably something, that's giving them hope, which is a good thing. But then being tempered with your response of, we're going to try some other things, or let's see how that works early if it seems like it's semi-credible, but we'll have some other options. So that's how I would take it, use it as an opportunity to engage versus feeling like you have to chase everything down and have the evidence rated for each thing that is brought to you.
Yeah, I like the idea of using it as a starting point for like the human connection that we know is an important component of developing trust.
Yeah, I mean, if one of your goals is to have an engaged patient, and this is the way, I don't want to shut that down. I just want to have that not be the only venue for engagement.
Speaking of social media and controversy, are there any controversial or unexpected takes about back pain that would get you thrown out of the room at the big annual meetings that you go to? Mine is that nobody should ever use a p-value again, and the biostatisticians don't like it when I say that.
I think with back pain, the range of what is controversial is so wide. Part of the controversy actually is saying we're not as far along as we could be. And remember, the people that are experiencing this are really the reason we're doing this. I mean, almost all the back pain researchers that mentored me and still stay active, a common theme is we all started in the clinic. And I still think we're trying to answer questions that patients had that we couldn't answer. And that was really humbling. I used to think how annoyed I would be if I brought my car to get fixed and the person who was fixing it was like, I don't know, we're going to try like this. And then maybe it's the brakes. And then if that doesn't work, we'll move somewhere else. And that was kind of where we were then. And in some ways we still are. I think we just have a little better understanding of the pain experience and we can help people move to a self-management model. Some of the things I was involved with early were controversial, but now, like the supported self-management, that's, like I said, a psychologically informed approach. When I started my research career, I remember talking to physical therapists and they would say, well, I only deal with the physical part of the pain. So I don't know why you're interested in the psychologic influence.
What you're saying is you sort of live in the controversy as a career.
Yeah, I guess, or the evolution of care to this understanding that people still ask, how do we tell if someone's pain is real or not? And that maybe is as close to controversy, and in that basically when someone tells you in pain, that means their pain is real. And that can be really controversial for some people who want that proof. When we talk to therapists and others about the psychologically informed, I'm like, we're not in a medical legal hearing here. We're trying to help the person. If they tell you their pain is 10 out of 10, you just write that down and move on to the next thing, because all they've told you is they're extremely distressed by their pain right now. And if we're going to ask them to play this silly game of rating it from 0 to 10, when they pick the highest number, I don't spend much time thinking, is that the right or wrong answer? Instead, the message is, this person came to me and is in a lot of distress, and I hope I can help see that lower. People get really annoyed when someone says it's 12 out of 10, as if you can't use that number. And that's another thing we'll say. So I guess that's my controversy is 12 out of 10 pain is okay because it's patient reported. And that is just a sign that they're really, really distressed and they want you to pay attention and they want your help.
Hey, if believe patience is your controversial take, I think that's great. That's a really positive way to sort of wrap up the conversation. As we close, what are you most excited about?
Well, it was, recording this podcast. So now that that's over, we're going to be started on a PCORI trial where we're going to look at pain navigation in the VA, where we have, in a prior trial, we developed a pain navigator, which is a role in the VA to help veterans fully understand their non-drug options and then facilitate a referral to one of those. So now we're doing kind of a pain navigator plus, where we're going to arm the pain navigator with some of the tools that are in the supported self-management, so that not only is the interaction with a pain navigator helping to facilitate a referral, there also may be some therapeutic elements of, increasing your knowledge of what pain is about, embedding some self-management approaches and things like that. So, that's another pragmatic trial, although it definitely has some explanatory elements too, based on our recent pragmatic trial that maybe was too pragmatic in some areas. So I am excited about that. I think daunted too, because anytime you start a new trial, the pain that is coming, a different type of pain. And I think sometimes when you're on an experienced trial team, that's a huge advantage, but also that's a little bit of what you're getting into. You also know you can handle it, but what you're getting into. It's kind of like getting the syllabus on the first day of the class. Like, I know I'm going to get through it, but I did not think we were going to have to write 3 papers this semester, that type of feel. So that's, I'm excited about that. We are in the dissemination phase for the AIM-BACK trial, and that excites me. I like to write still. So that's exciting too, getting to share our results with the world and seeing what the reaction is. Because I think we did some things well in that trial that will be of interest, and I'm looking forward to the reactions to that.
I'm so grateful to you for leading in this space. It's a very challenging scientific topic, and it's really inspiring to kind of hear the nuanced approach that you and Nikki and others who are leading this work are taking to what can be really challenging work, but really important work for patients and for communities. So thank you for being here, and thank you for all you've done in this area. And we're looking forward to having you back, hopefully at some point, to hear about all the perfectly smooth processes, how everything just went exactly as you planned for this new PCORI study.
The revisionist history episode.
We love that here. Thanks so much, Steve.
Yeah, thanks for having me. It was a lot of fun.
Well, that was a great conversation with Dr. Stephen George, who works with me at the DCRI and studies chronic back pain. It's so interesting to hear the journey of someone who has treated people in clinic and been frustrated with the lack of evidence-based approaches and misunderstandings about effectiveness of treatments, to see them and make their transition into research and begin to contribute to those evidence gaps. Steve is doing incredible work with pragmatic clinical trials and shared some of the amazing progress for several of those studies, including the PACBAC trial that looked at supported self-management and usual medical care and spinal manipulative therapy. And the results from that study were so interesting to hear about, particularly given the ability to shift some of those less invasive approaches earlier in the patient journey to try to manage pain in a more comprehensive way from the start, instead of immediately going to really invasive approaches. And it was so interesting to hear Steve talk about that as a reflection of this shift that we've seen in the management of chronic pain, from we have something that will cure you to we're going to provide you with the tools and resources that will help you best manage this condition and live your life knowing that it's going to ebb and flow over time. It was also really interesting to hear him talk about chronic pain as an element that kind of exposes some of the structural weaknesses of our healthcare system and some of the challenges with trying to get coverage for evidence-based treatments that aren't seen really as traditional medical interventions, as well as to kind of hear his vision for what a better design system might look like, including things like taking advantage of existing data and really leaning into that concept of the learning health system, where we test something out and then see if it works and then implement accordingly. Steve has a really exciting new trial with PCORI that is going to be examining additional approaches in this space, and talk a lot about why chronic back pain is well suited for pragmatic trials, despite some of the challenges, including, messiness of implementation that we see with those studies. So great to see someone who's so well positioned from his clinical background, as well as from his appreciation of evidence and data, to be carrying out this work and really contributing to the evidence base in a meaningful way. So thanks so much for joining me for this episode of Beyond the Endpoint. As always, I encourage you to share your thoughts by emailing our team at beyondtheendpoint@duke.edu. And don't forget to subscribe on SoundCloud, Spotify, Amazon Music, or Apple Podcasts. You can also connect with the Duke Clinical Research Institute on LinkedIn, or by following at DCRI News on X and Blue Sky.
This has been Beyond the Endpoint. Resources related to this episode are available on dcri.org/BTE. If you have any burning questions about clinical research or healthcare, drop us a line at beyondtheendpoint@duke.edu. We'd love to address your questions in a future episode.